How do you approach building a trusting relationship with a newly admitted resident with dementia who is fearful and resistant to care?
Building a trusting relationship with a newly admitted resident who is fearful and resistant requires a high degree of patience, a commitment to understanding their personal history. I recall admitting an elderly resident with advanced dementia who became anxious and refused personal care, often pushing staff away. The challenge was helping her feel safe while ensuring her needs were met. I began by spending time with her without rushing care, observing her reactions and learning her preferences, such as how she liked to be addressed and the activities that brought her comfort. I introduced myself at each interaction, explained each step calmly, and offered choices whenever possible, such as which clothes to wear or whether she wanted to wash at a sink or in bed. I also involved familiar objects from home, like a shawl or family photograph, to create a sense of familiarity. Consistency was key, so I communicated my approach with colleagues during handovers to ensure all staff interacted in the same gentle, reassuring way. I gradually introduced care tasks in short, manageable steps, praising her cooperation and celebrating small achievements. Over 2 weeks, she became more receptive, allowing assistance with personal care and engaging in conversation during activities. This experience reinforced that trust is built through patience, empathy, and consistent, person-centered interactions, which enable residents to feel safe, respected, and gradually more confident in their care environment.
Describe a time you managed a situation where a resident with dementia became verbally or physically aggressive.
I encountered this situation while working on a long-term care ward with a high number of residents living with moderate to advanced dementia. One evening shift, a male resident who was usually calm became verbally aggressive and began attempting to strike staff during personal care. This behavior was triggered when we tried to assist him with toileting, which he misinterpreted as a threat due to confusion and fear. My immediate responsibility was to ensure the safety of the resident, other patients, and staff while also preserving his dignity. I asked the healthcare assistant to step back and reduce stimulation by closing the curtains and lowering my voice. Instead of continuing the task, I repositioned myself at eye level and addressed him by name, using short, reassuring sentences. I acknowledged his distress rather than correcting him, which helped de-escalate the situation slightly. Once he was calmer, I gave him time and space, then reapproached after several minutes with a different strategy. I involved a staff member he trusted and used familiar cues, including explaining each step slowly and allowing him to hold a towel, which gave him a sense of control. I also assessed for possible underlying causes such as pain, constipation, or urinary discomfort and later documented the incident in detail. After the episode, I updated the care plan and communicated with a multidisciplinary team and his family. We identified that personal care late in the evening increased his agitation, so we adjusted his routine to complete care earlier in the shift. Over the following weeks, incidents reduced significantly and staff confidence improved. This experience reinforced the importance of patience, communication, and understanding behavior as a form of unmet need rather than intentional aggression. It also highlighted how adapting care approaches can lead to safer and more compassionate outcomes for residents with dementia.
How do you incorporate a person-centered approach into daily care for individuals with advanced dementia?
In my experience, providing person-centered care for individuals with advanced dementia requires consistency, patience, and a deep respect for who the person is beyond their condition. While working in a long-term care ward, I supported an elderly patient with advanced dementia who frequently became distressed during personal care, particularly in the mornings. This distress was affecting both her dignity and the efficiency of care delivery. To address this, I took time to learn more about her personal history by speaking with her family and reviewing her care records. I discovered she had been a primary school teacher and valued routine and calm communication. I adjusted my approach by introducing myself each time, explaining each step slowly, and maintaining eye contact. I also adapted the timing of care to align with when she was most settled, even though it required coordination with colleagues to adjust the daily schedule. During care, I used familiar phrases and encouraged small choices, such as selecting clothing, to promote a sense of control. I worked closely with a multidisciplinary team to ensure consistency so that all staff used the same approach. Within a few weeks, her distress reduced significantly, personal care was completed more smoothly, and she became more receptive to interaction. Her family commented on the improvement in her comfort and dignity. This experience reinforced that person-centered care in advanced dementia is not about complex interventions, but about understanding the individual, adapting routines, and advocating for care that respects their identity, preferences, and remaining abilities, even when communication is limited.
Describe your experience working with the families of individuals with dementia.
Working with families of individuals with dementia has been a central part of my nursing practice, as their involvement is essential to providing safe and compassionate care. In a medical ward where many patients were living with moderate to advanced dementia, I regularly supported families who were struggling to understand changes in behavior, communication, and functional ability. One particular experience involved the daughter of a patient with advanced dementia who was becoming increasingly anxious and questioning every aspect of care. I recognized that her anxiety stemmed from fear and lack of information rather than distrust. I arranged time to speak with her in a quiet space, explained her mother's condition in clear, non-technical language, and listened to her concerns without interruption. I also encouraged her to share her mother's routines, preferences, and life history, which helped us tailor care more effectively. As care progressed, I made a point of providing regular updates, even when there were no significant changes, and invited her to be present during care when appropriate. I also involved the wider team, including the consultant and occupational therapist, to ensure consistent messaging and realistic goal setting. Over time, her confidence in the team improved, communication became more open, and she began to participate positively in care planning. This experience taught me that families are often coping with grief and uncertainty. By being honest, approachable, and inclusive, I have been able to build trust, reduce conflict, and support families as partners in care, which ultimately improves outcomes and preserves the dignity of individuals living with dementia.
How would you handle a situation where a resident is consistently sundowning, disrupting the evening routine for others?
I have managed situations like this in a dementia care unit where one resident regularly became agitated and restless in the late afternoon, calling out and pacing, which affected the comfort of other residents during the evening routine. The main challenge was balancing his need for reassurance while maintaining a calm environment for the wider group. I began by reviewing his care notes and observing patterns over several days to identify triggers. I noticed his agitation increased after long periods of inactivity and when lighting levels changed. In response, I worked with the team to adjust his routine by introducing a short, structured activity earlier in the afternoon, such as guided walking or folding towels, which helped release excess energy. I also ensured the environment was well lit as daylight faded and reduced background noise where possible. During episodes of agitation, I used a calm, familiar approach, speaking slowly and offering reassurance rather than attempting to reorient him forcefully. I involved his family to learn about past routines and incorporated familiar music during the evening, which had a noticeably calming effect. Within 2 weeks, the frequency and intensity of his sundowning reduced. Evening care became smoother, and other residents were less disturbed. This approach demonstrated the importance of understanding triggers, adapting routines, and working collaboratively to manage behavioral symptoms effectively.
Explain how you ensure effective communication with a resident who has significant language deficits.
Ensuring effective communication with a resident who has significant language deficits requires patience, adaptability, and close observation. In a stroke rehabilitation unit, I cared for a resident with expressive and receptive aphasia who became frustrated during care, often withdrawing or refusing assistance. This created challenges in meeting his needs safely while preserving his dignity. I began by assessing how he communicated nonverbally, paying attention to facial expressions, gestures, and changes in behavior. I collaborated with the speech and language therapist to understand his remaining strengths and follow their guidance closely. I simplified my language, used short phrases, and allowed extra time for responses without rushing or interrupting. Visual prompts, such as picture cards and demonstrating actions, became part of our daily interactions. To support consistency, I share these strategies during handovers so all staff approach communication in the same way. I also confirmed understanding by observing his reactions rather than relying solely on verbal responses. Over time, his frustration reduced, and he became more engaged in care, particularly during personal hygiene and meals. He began using gestures more confidently to express preferences, which improved his sense of control. This experience reinforced that effective communication is not limited to speech. By adapting methods, working with specialists, and remaining attentive to nonverbal cues, I was able to build trust, reduce distress, and ensure the residents' needs were met safely and respectfully.
Describe a time you identified a change in a resident's condition that was not immediately obvious.
While working in a residential care facility, I was caring for an elderly resident with dementia who was usually calm, sociable, and independent with most activities of daily living. Over the course of 2 evening shifts, I noticed subtle changes that were easy to overlook. She became quieter, declined meals, and required more prompting with mobility, although her observations remained within normal limits. The challenge was recognizing whether this was a progression of her dementia or an emerging physical issue. I carried out a focused assessment, paying attention to hydration, bowel habits, and pain indicators, as she had limited verbal communication. I also reviewed her medication chart and noted she had recently started a new diuretic. I discussed my concerns with the senior nurse and requested basic investigations, including urine testing and blood work, while closely monitoring her input and output. The results confirmed a urinary tract infection and mild dehydration, neither of which had presented with obvious symptoms initially. Treatment was started promptly, and I supported her with increased fluids, regular toileting, and comfort measures. Within 48 hours, her appetite improved, her mobility returned to baseline, and her engagement with others increased. This experience highlighted the importance of knowing residents well, trusting clinical judgment, and acting early on subtle changes to prevent deterioration and avoid unnecessary hospital admission.
How do you promote dignity and independence during intimate personal care tasks?
Promoting dignity and independence during intimate personal care is a priority in my practice, particularly in long-term and dementia care settings. I recall caring for an older resident with reduced mobility following a hip fracture who felt embarrassed and anxious about needing assistance with washing and toileting. The challenge was supporting his physical needs while preserving his sense of autonomy and self-respect. I began by ensuring privacy at all times, closing doors and curtains, and explaining each step of care before starting. I asked for consent continuously rather than assuming agreement, and encouraged him to do as much as he could safely, such as washing his upper body and choosing his clothing. I adjusted the pace of care to suit him. Even during busy shifts, his rushing would have increased his distress. To support independence, I used appropriate aids, including grab rails and shower chair, and liaised with physiotherapy to ensure techniques aligned with his rehabilitation goals. I also maintained a respectful tone and avoided unnecessary exposure by using towels strategically. Over the following weeks, his confidence improved, he became more engaged in his care, and his mobility progressed as expected. This experience reinforced that dignity is maintained through respect, clear communication, and enabling individuals to remain active participants in their own care, even when they require significant physical support.
Give an example of how you have contributed to a positive and stimulating environment for residents with dementia.
In a dementia care unit where I worked, several residents were becoming withdrawn and disengaged, spending long periods sitting quietly with limited interaction. This was contributing to low mood and increased restlessness later in the day. I felt there was an opportunity to create a more stimulating environment without overwhelming residents or disrupting routines. I worked with 2 colleagues to introduce short, meaningful activities tailored to residents' abilities and interests. Using information from care plans and family feedback, we created simple activity boxes that included items such as familiar household objects, photographs, fabric, and music from residents' younger years. We scheduled these activities in small groups during mid-morning and mid-afternoon, when residents were most alert, and kept sessions to 20 to 30 minutes to prevent fatigue. I took the lead in coordinating the schedule and informally guiding staff on how to engage residents through conversation, touch, and observation rather than focusing on outcomes. Over the following month, we noticed residents smiling more, initiating interaction, and showing reduced agitation in the evenings. One resident who rarely spoke began singing along to familiar songs, which also encouraged others to join in. This experience showed me that a positive environment is created through thoughtful planning, teamwork, and understanding individual histories. Simple, consistent activities can significantly enhance well-being, connection, and quality of life for people living with dementia.
Describe a time you advocated for a resident with dementia.
While working in a long-term care facility, I supported a resident with moderate dementia who had begun refusing meals and losing weight over several weeks. Some staff felt this was an expected progression of her condition, but I was concerned that her needs were not being fully understood. The challenge was ensuring her voice was heard despite her limited ability to express herself clearly. I spent time observing her during mealtimes and noticed she became distressed in the noisy dining area and struggled with the texture of the food provided. I discussed my observations with a senior nurse and requested a multidisciplinary review. I also contacted her family to gain insight into her past eating habits and preferences, which revealed she had always preferred smaller portions and a quieter environment. Following this, I worked with a dietitian and speech and language therapist to adjust her meal plan, introducing softer foods, finger foods, and the option to eat in a calm side room. I ensured these changes were clearly documented and communicated to all staff. Within 2 weeks, her food intake improved, she gained weight gradually, and her distress at mealtimes reduced significantly. This experience reinforced the importance of speaking up, using observation and collaboration to advocate effectively, and ensuring that residents with dementia receive care that reflects their individual needs and dignity.
How do you manage your own emotions and stress when dealing with challenging behaviors or emotional situations?
Managing my own emotions and stress is essential to providing safe and compassionate care, particularly when supporting residents with challenging behaviors. While working in a dementia unit, I regularly cared for a resident who became verbally aggressive during personal care, especially when feeling rushed or overwhelmed. Initially, these interactions were emotionally demanding and had the potential to escalate if not handled carefully. I learned to pause and assess my own response before engaging, focusing on remaining calm and controlled in my tone and body language. If I felt my stress levels rising, I used brief grounding techniques such as slowing my breathing and asked a colleague to step in when appropriate. I also reflected on triggers for the resident's behavior by reviewing care notes and discussing patterns with the team, which helped me approach situations with understanding rather than frustration. Outside of direct care, I made use of supervision and informal debriefs with colleagues after difficult shifts, which helped me process emotions and learn from others' experiences. I also ensured I maintained boundaries by taking breaks and using annual leave effectively to prevent burnout. As a result, I became more confident in managing difficult interactions, incidents reduced, and care was delivered more consistently. This approach has helped me remain resilient, empathetic, and professional, even in emotionally challenging situations.
Describe a time you collaborated with other healthcare professionals to improve a resident's care.
While working in a residential care facility, I supported a resident with dementia and reduced mobility who had begun experiencing frequent falls over a short period of time. Although no serious injuries had occurred, the repeated incidents were affecting his confidence and increasing anxiety for both staff and family. The challenge was addressing the issue without unnecessarily restricting his independence. I raised my concerns during a multidisciplinary meeting and shared specific observations, including the times of day the falls occurred and changes in his gait. I worked closely with the physiotherapist, occupational therapist, GP, and care staff to review his mobility, environment, and medication. The physiotherapist adjusted his exercise program to focus on strength and balance, while the occupational therapist assessed his room and recommended minor environmental changes, such as improved lighting and repositioning furniture. The GP reviewed his medications and identified one that was contributing to postural hypotension. I ensured these changes were clearly documented and communicated during handovers, so all staff followed the updated care plan consistently. Over the following month, the number of falls reduced significantly, and the resident became more confident mobilizing with support. This experience reinforced the value of collaborative working, clear communication, and shared decision-making in achieving safer, more effective, and person-centered care.
How do you approach nutritional and hydration challenges in dementia care?
Addressing nutritional and hydration challenges in dementia care requires careful observation, creativity, and collaboration. I recall caring for a resident with moderate dementia who began refusing meals and losing weight over several weeks, which raised concerns about malnutrition and dehydration. The challenge was identifying the underlying causes and supporting intake without causing distress or conflict. I started by observing her closely during mealtimes, noting which food she tolerated, her preferred textures, and times of day when she was most alert. I consulted with a dietitian and speech and language therapist to adapt her diet with softer foods, smaller portions, and finger foods that she could manage independently. I also involved her family to understand her past eating habits and incorporated familiar foods that were culturally meaningful, which encouraged engagement. To support hydration, I introduced regular small drinks throughout the day, using cups with handles and visual cues, and encouraged staff to offer fluids consistently rather than only at mealtimes. I monitored intake meticulously, recording amounts and any refusals, and shared this information at handovers to maintain continuity. Within a few weeks, her intake improved, weight stabilized, and her mood and engagement increased. This approach demonstrated that by understanding individual preferences, adapting routines, and collaborating with colleagues, nutritional and hydration challenges in dementia care can be addressed effectively while preserving dignity and independence.
Describe your process for documenting and reporting changes in behavior or condition.
Accurate documentation and timely reporting are essential when caring for residents whose condition or behavior can change subtly. In a dementia care setting, I supported a resident who was usually settled and cooperative but began showing increased agitation, pacing, and sleep disturbance over several shifts. Although there were no obvious physical symptoms, the pattern was concerning and required careful handling. I began by recording objective observations in her daily notes, focusing on what I saw rather than assumptions. This included the time the behaviors occurred, what preceded them, how long they lasted, and how she responded to reassurance or intervention. I also documented changes in appetite, fluid intake, and sleep, ensuring entries were clear, factual, and consistent with professional standards. Alongside written records, I escalated my concerns verbally to the nurse in charge and raised the issue during handover so patterns were not missed across shifts. I completed appropriate monitoring tools and requested a clinical review, which led to further assessment. As a result, an underlying urinary infection and pain issue were identified and treated promptly. Once her condition improved, her behavior returned to baseline. This experience reinforced the importance of clear, timely documentation and proactive reporting. By combining accurate written records with effective verbal communication, I help ensure changes are recognized early and appropriate action is taken to protect residents' safety and well-being.
How do you respect and support a resident's cultural and spiritual needs?
Respecting and supporting a resident's cultural and spiritual needs is central to providing person-centered care. In a multicultural care setting, I supported a resident from a South Asian background who became increasingly withdrawn, particularly around mealtimes, which coincided with certain religious practices and dietary preferences. The challenge was ensuring her needs were met while integrating seamlessly with the routines of the wider ward. I began by speaking with her family to understand her beliefs, daily rituals, and preferred foods. I liaised with the catering team to ensure meals were culturally appropriate and prepared in line with her dietary restrictions, and I coordinated with colleagues to allow time for prayer or meditation without disrupting other residents' routines. I also incorporated aspects of her culture into activities, such as traditional music or storytelling, which help her engage more fully and feel a sense of familiarity and comfort. Additionally, I documented these preferences in her care plan and communicated them clearly during handovers so that all staff approached her care consistently and respectfully. Over time, she became more relaxed, engaged in communal activities, and expressed appreciation through increased verbal interaction and improved mood. This experience reinforced that acknowledging cultural and spiritual identity is not an add-on but an essential part of holistic care, contributing to emotional well-being, dignity, and meaningful engagement for residents.
Give an example of a creative or non-pharmacological intervention you have used to address anxiety or agitation.
In a dementia care unit, I cared for a resident who became increasingly agitated in the late afternoons, frequently pacing and vocalizing distress, which disrupted both her own comfort and the calm of others. Rather than relying immediately on medication, I sought non-pharmacological strategies to address her anxiety. I reviewed her care history and spoke with her family to understand her past routines and preferences. I learned she had been an avid gardener and found outdoor activity calming. Using this knowledge, I introduced a small, structured activity in the secure garden area, involving planting and tending to potted plants. I timed the sessions in the late afternoon, when agitation usually began, and ensured staff support while allowing her to work at her own pace. During the activity, I used gentle guidance and encouragement, providing choice and acknowledging her achievements, which helped maintain her sense of control. I also paired the activity with familiar music in the background, creating a multisensory, calming environment. Within a week, the frequency and intensity of her agitation decreased noticeably, and she began engaging in conversation with staff and other residents during these sessions. This experience demonstrated that thoughtful, personalized interventions grounded in an individual's history can effectively reduce anxiety and improve well-being, while supporting autonomy and dignity without relying on pharmacological measures.
Describe a time you made a mistake in dementia care and what you learned from it.
Early in my practice on a dementia ward, I once administered a routine medication to a resident without double-checking their most recent prescription change. The resident had recently been switched to a lower dose due to kidney function concerns, and my oversight led to them receiving a slightly higher dose than intended. Thankfully, the resident showed no immediate adverse effects, but the incident was taken seriously. I immediately recognized the error, informed the senior nurse, and followed the facility's incident reporting procedures. We monitored the resident closely, and I ensured the situation was documented accurately. I also reflected on what had contributed to the mistake, identifying that I had been distracted by a busy shift and had relied on memory rather than verifying the updated medication chart. To prevent recurrence, I revised my personal process, adopting a consistent habit of checking the latest prescription against the resident's identification at every administration, and I share this practice with newer colleagues during informal mentoring. I also became more mindful of minimizing interruptions during medication rounds. This experience reinforced the importance of vigilance, structured routines, and open communication. Mistakes can happen even with good intentions, but responding promptly, learning from the situation, and implementing practical safeguards strengthens patient safety and professional practice in dementia care.
How do you support a resident who is experiencing hallucinations or delusions?
Supporting a resident experiencing hallucinations or delusions requires a calm, patient, and empathetic approach. In a dementia care unit, I cared for a resident who frequently believed that strangers were entering her room at night and became highly anxious, which affected her sleep and overall well-being. The challenge was addressing her distress without reinforcing the delusion or causing further fear. I began by observing patterns and triggers, noting that her episodes often occurred when lighting was low or when staff moved quickly around the ward. I responded by remaining calm, speaking in a gentle, reassuring tone, and validating her feelings rather than arguing or trying to correct her perception. I redirected her attention to familiar, comforting activities, such as looking through a family photo album or listening to music she enjoyed, which helped reduce anxiety. I also collaborated with a multidisciplinary team, including the GP and psychologist, to ensure any potential underlying causes, such as infection or medication effects, were considered. The approach was consistently communicated during handovers so all staff used the same strategies, providing continuity and reassurance. Over time, the frequency and intensity of her episodes decreased, and she became calmer during the evening routine. This experience reinforced that responding with empathy, consistency, and environmental adjustments, rather than confrontation, is essential in supporting residents experiencing hallucinations or delusions while maintaining safety and dignity.
Explain how you contribute to ensuring a safe environment for residents with dementia.
Ensuring a safe environment for residents with dementia is central to my practice, as even small hazards can have significant consequences for this population. In a memory care unit, I cared for several residents prone to wandering and falls, which required vigilance and proactive measures. I began by conducting regular observations and environmental checks, paying attention to trip hazards, adequate lighting, and secure access points. For one resident who frequently attempted to leave the unit unsafely, I collaborated with a multidisciplinary team to implement subtle modifications, such as visual cues and discrete door alarms, rather than restrictive measures. I also ensured that furniture and equipment supported safe mobility, arranging walking aids within easy reach and keeping floors clear of obstacles. In addition, I maintained clear communication with colleagues, reporting any incidents, near misses, or concerns promptly during handovers, and ensuring care plans reflect current risks and preventive strategies. I also engage residents in familiar routines and activities, which reduces restlessness and wandering, indirectly improving safety. These actions have contributed to a measurable reduction in falls and incidents in my unit, and residents are able to move with greater confidence and independence. I have learned that creating a safe environment for people with dementia requires constant observation, collaboration, and a balance between protection and respect for autonomy.
Why are you passionate about dementia care, and what do you find most rewarding?
My passion for dementia care stems from a desire to support individuals at a time when they are most vulnerable and often misunderstood. Early in my career, I cared for a resident who was frequently withdrawn and frustrated due to communication difficulties and memory loss. Over time, through patient interaction, learning about her life history, and tailoring care to her preferences, I noticed small but meaningful changes. She began to smile more, engage in conversation, and participate in daily activities. Witnessing these moments reinforced why dementia care is so important to me. What I find most rewarding is the opportunity to preserve dignity, autonomy, and quality of life for people whose cognitive challenges might otherwise overshadow their individuality. Helping a resident feel heard, valued, and comfortable, even through nonverbal communication or simple gestures, creates profound connections that are deeply meaningful for both the resident and their family. I'm also motivated by the challenge of adapting care creatively to each individual's needs, whether through personalized activities, environmental adjustments, or supporting families to understand and engage with their loved one. Seeing improvements in well-being, even small ones, and knowing that my actions directly contribute to a resident's comfort and happiness is what drives my commitment and continual growth in dementia care.